Good morning, good afternoon, everyone. My name is Andrea Hawkinson, and I am the Global Medical Affairs Lead for the Metabolic Health category with Nestle's Health Science. And so I'd like to thank everyone for taking the time to join us today for the webinar, The Clinical Efficacy and Cost Effectiveness of Meal Replacements for Weight Management, Achieving Improved Management of Comorbidities and Diabetes Remission. Now it's my pleasure to introduce our first speaker, Dr. Amy Rothberg. So Dr. Rothberg is the professor in the Division of Metabolism, Endocrinology, and Diabetes, and also the professor of nutritional sciences in the School of Public Health at the University of Michigan. She is the director of the University of Michigan Weight Management Program, a clinical research program in which patients undergo extensive phenotyping to identify the factors that predict successful and cost-effective long-term weight loss. Her primary research is funded by the NIDDK and NICHD for studies examining the biopsychosocial and neurohormonal aspects of obesity and its related metabolic diseases. She has published articles on the epidemiology of obesity and diabetes and clinical outcomes, cost effectiveness of treatment of lifestyle or effectiveness of lifestyle intervention for obesity, as well as the impact of weight loss on reproductive function, diabetes remission, health-related quality of life, metabolic syndrome, pain, and neuropathy. Today, Dr. Rothberg's presentation is titled Dollars and Cents of Very Low-Calorie Diets, Clinical Outcomes, and Cost Effectiveness, and that will focus on very low-calorie diets using meal replacements and the impact on weight loss, weight-related comorbidities, health-related quality of life, costs, and cost effectiveness. Following Dr. Rothberg's presentation, I will step in again and introduce our second speaker, Dr. Mike Lean from the University of Glasgow in Scotland. And then following his presentations, there will be a live Q&A. So if you have questions during the presentation, please feel free to go ahead and post them in the chat box, and then we hopefully will try to address them during the Q&A. And then lastly, before I hand it over to Dr. Rothberg, I would like to make the disclaimer that if you see at the top of your screen, the webinar is being recorded for educational purposes only. So now I'd like to turn it over to Dr. Rothberg.
Thank you very much, Andrea. And in fact, I'd like to thank Nestle and Andrea Hawkinson for putting this together and inviting me to give this talk. Let me see how well I do about opening my tray. Let's see. Hoping everybody can see this. So as Andrea said, I'm going to be talking about clinical outcomes other than type 2 diabetes and cost of. So I first want to pose this question: what's the threshold or percent weight loss from a high BMI required to reduce complications from excess adiposity? And so I put together this table, and I think we all know that from the diabetes prevention program and like studies such as the Finnish diabetes prevention study, in which they took people at high risk of diabetes based upon oral glucose tolerance testing and targeted a weight loss of 7% and achieved that in 3/4 of the cohort, but showed that as little as 5% translated to a risk reduction of 58%. However, for most other comorbid health conditions related to a higher BMI, I think we need to target or be more aggressive about our targets, and that is about 10%, if not higher. Today, I'm going to be focusing down here on pain syndromes and reproductive outcomes. So first, we have to understand that obesity has economic implications that include excess sick leave, loss in productivity, and excess healthcare costs. In fact, the annual cost of having obesity for a woman is about $4,900 and for a man, $2,600. And the costs for obese individuals are 15 times higher than the total cost of being even overweight, irrespective of gender and employment status. And if obesity rates continue on their current trajectory, medical costs, at least in the US, associated with obesity will increase to as much as $66 billion per year. Conversely, weight loss interventions have been found to be cost effective, as little as $830 to $12,640 quality adjusted life year gained. And I'll talk about that at the end of my talk. And a sustained 10% reduction in body weight would decrease expected lifetime medical care costs of high blood pressure, high cholesterol, diabetes, heart disease, and stroke by $2,200 to as much as $5,300 for women and men, respectively. There are other cohorts or populations that are affected by obesity and also contribute to costs. For example, maternal and newborn care are the largest single category of hospital expenditures for commercial insurers and state Medicaid programs. And the cumulative cost of 4 million annual births exceeds $50 billion, and a mother with obesity increases that cost 2 to 3-fold. So here on the left, I'm just showing you the increasing rates of obesity among women in reproductive years between 2007 and 2017. Unfortunately, 50% of women presenting to their first prenatal visit are either overweight or obese, and 7% of women in their reproductive years have severe obesity, that is a BMI of 40 or greater. And our children and adolescents are not immune. Among children and adolescents aged 2 to 19 years old, about 1 in 6 were considered to have obesity, and 1 in 17 were considered to have extreme obesity. It's even worse among adolescents or our teens, ages 12 to 19, for whom 1 in 5, or about 21%, were considered to have obesity, and 1 in 11 were considered to have extreme obesity. Similarly, simulation models predict that 2-year-olds with obesity have a 75% probability of having obesity by the time they're 35 years old. And based upon current BMI levels, nearly 60% of our children will have obesity by the time they're 35. And among children with severe obesity, the likelihood of not having obesity by the time they're 35 was 27% in 2-year-olds and 6% in 19-year-olds. So here was a group out of Boston looking at the association of maternal pre-pregnancy, that is preconception weight, with offspring adiposity throughout adulthood over 37 years of follow-up. So the researchers ascertained maternal pre-pregnancy weight status using a combined measure of directly measured data and questionnaire data. So directly measured maternal pre-pregnancy BMI was obtained from study examinations of participants in the original cohort, that is cycles between 1948 and 53 and 1950 and 55. So the eligible study population included 863 participants, 83 of whom were exposed and 780 unexposed. 53% of the offspring were female, who at baseline, so examination 1, had a mean age of 33 and a mean BMI of 24.5. But at the end of follow-up examination, that is examination 8, they were 66 years old and had a mean BMI of 28. So here I'm just showing you the association of mom's pre-pregnancy weight category with offspring overweight at the 8 Framingham Heart Study examination cycles. The odds of having obesity at every examination cycle were elevated among offspring exposed to maternal overweight or obesity compared with unexposed. And examination cycle 1, you can see that there was 2.5-fold higher odds of having obesity in the exposed compared to the unexposed. So I'm just showing you on the left the unadjusted mean BMI, and on the right the prevalence of obesity of offspring exposed to maternal obesity or overweight here with the red line slope compared to the unexposed or normal controls. So obesity among women of reproductive age has contributed to abnormalities across the reproductive spectrum, including, as I've listed here, risk of miscarriage, infertility, and perinatal complications. And for the offspring, stillbirth, metabolic and developmental abnormalities, and for the offspring, of course, increased risk of adiposity and cardiometabolic consequences. Oh, same thing is happening and I can't advance. So I got stuck and I'm not sure what to do.
Let me.
Something I hit. Apologize to the audience. Well, perhaps.
Hari, do you? Technical difficulties here. Sorry about that.
I'm going to stop sharing for a minute.
Okay, maybe try that. Yeah. Yeah.
Okay. Can we see that now? Okay. So I'll try not to do that. So it is this in utero experience that is the ultimate diviner or shapes offspring, weight, and health. And just so you know, there have been many magazine articles in the lay press that have discussed the importance of that in utero environment. So the developmental origins of health and disease began with the observation from Barker and Osmond that described an association of lower birth weight and an increase in cardiovascular disease. But since that initial observation, it's become clear that nutrition, endocrine disrupting chemicals, or environmental stress have contributed to a maladaptive in utero environment and shapes offspring health. So we know that maternal and paternal obesity status, less is known about paternal obesity status, but can cause epigenetic disruption in offspring. These are modifications on top of DNA, such as DNA or hyper and hypomethylation, histone deacetylation, and changes in the microRNAs. And these lead to alteration in gene expression, protein expression, and then the clinical outcomes that we see. Both undernutrition and now more importantly, overnutrition lead to these epigenetic changes in utero and then across the lifespan. So it is this maladaptive programming that leads to the downstream lifelong consequences for that offspring. So we know that studies of lifestyle interventions have been, lifestyle interventions themselves have been woefully inadequate. And these are just studies of analyses of lifestyle interventions done in pregnancy. For example, Dodd studied 9 RCTs that include 743 overweight or obese pregnant women and showed that there was no effect of interventions designed to limit gestational weight gain on weight gain or on delivery of a large gestational age infant. Tangarantanam looked at 44 studies of a combination of lifestyle across all BMI ranges and found a modest 1.5 kilogram reduction in gestational weight gain with any intervention versus control. Physical activity alone was associated with a reduction in body weight, but diet was the most effective with reductions in maternal gestational weight gain and a modest improvement in obstetrical outcomes, so proximate outcomes, in women with overweight, but not women with obesity, and there was no reduction in large for gestational age infants. Therefore, as I've said, lifestyle interventions during pregnancy have only a modest effect of reducing downstream consequences. So obesity is the most common healthcare problem in women of reproductive age. The implications relative to pregnancy often are unrecognized, overlooked, or ignored because of the lack of specific evidence-based treatment options. So an understanding of the management of obesity during pregnancy is really vital, and management should begin before conception and then, of course, continue through the postpartum period. So despite irrefutable evidence that obesity negatively impacts reproductive outcomes and compromises maternal and fetal health, few studies have been actually performed to estimate the impact of medical weight loss on reproductive outcomes. So in our study, we're taking women with obesity, so BMIs between 30 and 45, and randomizing them to either very low calorie diet with TMR with a target weight reduction of 15% from baseline weight, or to standard of care nutrition education and dietary counseling. We're performing clinical and molecular phenotyping at baseline and then after weight loss. We're also following a group of normal weight women in parallel, but our objective is to determine if offspring fat mass, as measured by PPOD on days 1 through 3, differ among the three groups. What we're most interested in is the offspring rate of growth through 12 months of age. But our overall hypothesis is that aggressive preconception weight loss with VLED in obese women will improve the metabolic health of both the mother and the intrauterine environment, and that optimized intrauterine environment will translate to improved fetal and offspring outcomes and theoretically reduce the susceptibility to obesity and cardiometabolic disease later in life. So here I'm just showing you a cohort derived from this study. Here are women who are lean, obese, and obese post weight loss. And as you can see, they had a nice reduction in BMI to the tune of almost 7 units or 7 kilograms per meter squared, and had vast improvements in fasting glucose, fasting insulin, and HOMA-IR or insulin sensitivity. Here on the right, I'm showing you just a heat map of those women in table 2. So the lean, the women pre and post weight loss. The heat map is just showing you the relative levels of 667 lipid species. And these are some of the more important lipid species that had changes relative to this diet. The heat map showing red, which is an increase, or a green showing a decrease in levels. Here I'm just showing you in plot B the logarithmic mean differences in triglycerides in the pre-weight loss compared to lean in red, and then the post-weight loss compared to lean in blue. So more than 1 in 3 women entering pregnancy has obesity. Maternal obesity is a strong predictor of childhood obesity, and excess weight prior to pregnancy introduces significant epigenetic reprogramming, and we need to really do more to interrupt this vicious cycle. So I'm going to pivot now and talk about another dual epidemic, that is obesity and pain. The National Health Interview Survey in 2010 found that nearly 20% of Americans report persistent pain, and obesity increases that risk by 60%. Obesity also exacerbates symptoms when chronic pain is already present. In fibromyalgia, for example, obesity is associated with worse sleep, greater fatigue, and more sensitivity to palpation. So I think we have or harbor this classic view of pain. That is that excess adiposity increases the mechanical load or burden on the weight-bearing joints, and also inflammation in those weight-bearing joints. But I think we need to consider an alternate view, and I think this says been shown just in terms of the COVID pandemic that obesity really is an inherently inflammatory disease, and that adipose tissue is a dynamic endocrine organ that releases pro-inflammatory cytokines. Monocytes take up this pro-inflammatory phenotype in adipose tissue, and that these immune factors go on to sensitize our central nervous system. So we studied 123 participants with a very high BMI, 2/3 of whom were female, and endorsed pain in at least one body site at the time of study entry. And we measured pain at baseline and after weight loss using the 2011 fibromyalgia survey criteria. And some of the cohort provided serum before and after the intervention for analysis of inflammatory markers just listed below, including, for example, interleukin-6, 1-beta, 10, TNF-alpha, and interferon gamma. Weight loss on average using VLCD was 16%. And here I'm just showing you a cartoon of those who lost 10% or greater from baseline weight versus those who lost less than 10%. And as you can see, they were the minority of the cohort. Blue represents improvement, white no change, and red worsening. And the diameter of this circle is the percent endorsing pain at baseline. So just from this, you can see that there were marked improvements in those who lost 10% or greater, and there are more variable changes in those who lost less than 10%. Depression also improved. There was an average 33% reduction, and there was an average 15% reduction also in fatigue. Here, this correlated, and I'm just showing you one of the anti-inflammatory cytokines, that is IL-10, blue representing before weight loss, and orange representing after weight loss. And you can see there were statistical improvements and similar patterns in terms of the ratio of IL-10 to CRP. So here I'm just showing you the weeks on diet, baseline week 3, week 6, for example, and the fibromyalgia survey scores. And these were stratified by low improvement in blue, moderate improvement in red, and a high improvement in green. But what was very curious and interesting is that these changes occurred very early on, as early as 3 weeks into caloric restriction. And this was independent, of course, of the weight loss observed, as you can see here on the x-axis BMI. It made very little difference in terms of the notable improvements. Indeed, 28% of people endorsed less than 30% improvement. However, nearly a quarter endorsed 30 to 50% improvement, and almost half of the cohort endorsed 50% or greater improvement. So pain, fatigue, and depression are improved by this VLED intervention. Increased anti-inflammatory activity may be responsible, and these changes occurred early, suggesting that this aggressive caloric restriction, or VLED with TMR per se, may promote analgesia. So lastly, in the few minutes I have, I'm going to talk about cost effectiveness. So cost effective analysis describes the cost per unit health outcome obtained with an experimental intervention versus usual care. And it provides a measure of the value obtained for the money spent, and may, and actually does, guide a lot of our resource allocation. So quality adjusted life here adjusts length of life for quality of life. So it is the product of the time and the health state multiplied by the quality of life in the health state, where quality of life equals the health utility, 1 representing excellent health and 0 representing death. There are a number of multi-attribute utility models, and we in our program use the EuroQual or EQ5D by Shaw et al. So, for example, if we spend 20 years of life in excellent health, it is 20 times 1, 1 being the excellent health, equals 20 quality adjusted life years. Whereas if we spend 20 years of life, 10 are spent in excellent health, but another 10 are spent with blindness. That is 10 times 1 plus 10 times 0.51, which is the health utility for blindness, equals only 15.1 quality adjusted life years. This is a visual analog scale where 100 represents the best imaginable health and 0 represents the worst imaginable health. And we just ask our participants to draw a line through a number representing their health state. So most previous studies have assumed that health-related quality of life is determined by BMI, and that after weight loss, an obese individual's health-related quality of life is the same as that for a person with the same BMI who did not lose weight. In other words, if we lose weight from a BMI of 45 to 30, we're making the assumption that that person's BMI is the same for somebody who has lived most of their life at a BMI of 30. And to the extent that individuals with obesity underestimate the impact of pre-intervention weight on health-related quality of life, and to the extent that their health-related quality of life after weight loss is better than predicted by their reduced body mass index, cost-utility analyses will underestimate the value of treatments for obesity. So obesity, as we know, increases the risk for many chronic conditions, including type 2 diabetes and cardiovascular disease, and does negatively impact quality of life. And although there's a large body of evidence that suggests that the treatments are the effectiveness of treatments for obesity, there's very or less and limited evidence about the cost utility of these interventions. And some of these, the evidence has been unfortunately inconsistent. So our purpose in was to describe the factors associated with improvements in health-related quality of life after weight loss, and to also assess the relationship between obesity based on body mass index and health-related quality of life before and after weight loss. So we looked at 188 patients with a mean BMI of 50 and a mean BMI of 40. So again, having severe obesity. Baseline health utility score was 0.85, and again, 100 being or 1 being the top, so they are underestimating the impact, and their visual analog score was 0.67. So I'm just going to summarize the study, but a medical weight management program that involved very low calorie diet for 12 weeks, asking people to get engaged more regularly and consistently in physical activity, and providing intensive behavioral counseling resulted in substantial weight loss and improved health-related quality of life. The mean weight loss observed at 6 months was 45 pounds. Mean improvement in EQ5D index was 0.06. So a change of 0.03 is both clinically meaningful and statistically significant. And there was a mean improvement in VAS by 0.14. So participants with lower baseline BMI, so this is relative because they had moderate to severe obesity, greater reduction in BMI from baseline to follow-up, fewer baseline comorbid health conditions, and a poorer baseline health-related quality of life, had greater improvements in health-related quality of life at follow-up. Here I'm just showing you the association between BMI and visual analog scale at baseline and 6 months follow-up as a function of BMI. So solid circles and solid line are baseline, and open circles and dotted line are at follow-up. For any given BMI category, EQ5D and the VAS shown here tended to be higher at follow-up than at baseline, and measured improvements in VAS between baseline and follow-up were greater than was predicted by the reduction in BMI at baseline. So lastly, our results confirm the results of previous studies. That is that an improvement in health-related quality of life for each kilogram lost or percent body weight lost is greater than would be predicted by assessing the cross-sectional relationship between BMI and health-related quality of life, and assuming that individuals with obesity's health-related quality of life after weight loss is the same as that for a person with the same BMI who did not lose weight. At baseline, as I've said, patients appeared to underestimate the negative impact of obesity on quality of life, and after weight loss reported significantly better quality of life for any given BMI category. Failure to use a sensitive instrument and failure to empirically assess quality of life both before and after weight loss will underestimate the improvement in quality of life associated with weight loss and underestimate the cost utility of interventions for obesity treatment. And this is incredibly important because we need payers to pay for effective lifestyle interventions. So I'll leave it at that, and I'll turn it back to Andrea. And thank you for your attention. Did I close my share tray? No.
Oops, sorry, I've been on mute. So thank you, Dr. Rothberg, for that really exceptional presentation. Very comprehensive. I certainly can appreciate the value now of really the impact of treatments for obesity. So now it's my pleasure to introduce our second speaker, Professor Mike Lean. So Professor Mike Lean is a professor of human nutrition at Glasgow University in Scotland and serves as a consultant physician at the Glasgow Royal Infirmary with NHS responsibilities for an acute medical ward and emergency receiving duties. He's also held the positions of visiting and adjunct professorships at the Robert Gordon University, Aberdeen, the University of Otago, New Zealand, and at the University of Sydney, Australia. Professor Lean has published over 600 scientific articles and books and currently leads broad-focused translational, integrative research and teaching within medical and nutrition training. And he has received several awards, including the Diabetes UK Rank Prize Lecturer, Banting Memorial Lecturer, Tenovius Medal for Research, and the elected Fellow of Scotland's National Academy. He's also the PI on the largest research grant ever awarded by the Diabetes UK, the Diabetes Remission Clinical Trial, otherwise known as the DIRECT trial, an NIH-funded weight loss for long COVID redirect and pharmaceutical trials as well. So clearly, very extensive research. So today in Dr. Lean's presentation titled Use of Total Diet Replacement to Achieve Sustained Weight Loss and Diabetes Remission, he'll discuss the role of insulin resistance in the pathophysiology of type 2 diabetes, review key learnings from clinical studies that evaluated the use of meal replacements as total diet replacement to achieve weight loss and improved glycemic control or remission, and then also present the current evidence to support the potential of total diet replacement and meal replacements to modulate pathophysiological processes involved in type 2 diabetes. So now it's my pleasure to hand it over to you, Professor Lean.
Thanks very much, Andrea, and I'm very pleased to be able to talk a little bit and tell you about some of our research. I'm going to, without further ado, try and share my screen. Yes. Now, when I kind of came into this part of my career, I noticed several things. That in this pathway, weight gain is a factor in driving nearly all the elements of that process leading to diabetes. And of course, we know that epidemiologically, type 2 diabetes is found only in people who are overweight or almost exclusively overweight. And I'm going to come back to what I mean by that. Amy Rothberg has explained a little bit about the complications of obesity. If we have obesity with diabetes, this is a dreadful condition, and the list here is pretty endless. These are looking at UK data, they're the same in North America. It is the commonest cause of blindness. It's the commonest cause of kidney failure and needing a transplant, the commonest cause of amputations and gangrene of the legs. It causes neuropathies and impotence, dementia, premature heart disease, of course, and increased cancer risks. And of course, it then puts people in the position where they're on many, many drugs with all the complications of being on many, many drugs and costs to the individual, costs to families, costs to society. And this tells us, a slide here tells us about the life expectancy of people with type 2 diabetes. And this is a very big European study, massive European study. And what it shows is men and women, pretty much the same story. With the y-axis are years of life lost. In other words, the years of life you would die younger than somebody without diabetes. And if you get your diabetes age 90, please don't worry about it, or even 80. It really isn't going to make much of a difference. 70 is beginning to cut in, but go down to I made the slide when the average age of onset was 55, you're going to lose 5, 6, 7 years of life. And below that age, the years of life lost increase. And those years of life are lost because of complications which are painful and disabling. So this is a very, very bad disease. I mentioned here that it's such a common disease that all the drug companies in the world have been trying to make drugs for it. And there are currently 488 different drugs and combinations of drugs licensed and approved to treat type 2 diabetes. This is in different countries, not all in the same country, but masses and masses of drugs. And all that the drugs do is sort of artificially lower the blood glucose. And that it's good, but it doesn't take the disease process away, the disease which is leading on to the complications. And those ghastly complications remain. Now here's putting it in another perspective. I've shown here the most up-to-date data with the 10-year survival for 3 diseases. 10-year survival means the proportion of people who will live another 10 years after diagnosis. Now, breast cancer, most people would regard as a pretty worrying diagnosis. If you're told you've got breast cancer, you take that seriously, and you would take treatment and you go through with the treatment, even if the treatment is not very pleasant. And it might be drugs, it would be chemotherapy, it could be surgery. But the likelihood is that you would go through with it absolutely, and you wouldn't take off a few days for a holiday or say, oh, I don't think I'll have it today, or I'll give it a miss this week because I've got a wedding. No, you would take it very seriously. Lymphoma, non-Hodgkin's lymphoma, much more serious cancer, 60% 10-year survival. And again, we treat it very, very seriously. Now look at type 2 diabetes, 50%. That's an even worse outlook than non-Hodgkin's lymphoma. So this disease that we've tended to slightly ignore or regard as a feature of aging or just being a bit tubby, and we treat it in a very minor kind of way, it is a more serious disease than some major cancers. And we have to reverse our thinking about these diseases. I don't mean to run down, belittle cancers. These are serious diseases, but type 2 diabetes is actually even more serious. That's a quite frightening thought. Now, I mentioned that we knew that weight gain causes this disease. This is a very famous slide from Graham Colditz using American data, and it shows us how the relative risk on the y-axis of type 2 diabetes compared to somebody who has a body mass index of 22 or 23, and that's me, up on the top of a mountain, down at the left there, how it goes up extraordinary levels. Most epidemiologists get worried about a body mass, about a relative risk of 2 or 3. Here we're looking at a relative risk of, well, with a body mass index of 25, it's about 8 to 10. With a body mass index of 30, it's about 30 to 40. And it goes on higher up into these extraordinary levels of risk. Now, you can't get that level of risk by coincidence. This is pointing to a causal relationship. And it tells us, because of the epidemic of diabetes, type 2 diabetes, which is the numbers have been doubling every decade, and they're continuing to double, completely in line with the epidemic of overweight and obesity, such that we're using the word syndemic now, which means you've got 2 epidemics which are synchronous and linked. Syndemic. So it's obesity, or overweight and obesity, causing diabetes at a global level, and people who who've got diabetes now, had they remained with a body mass index of 22 or 23, would not have type 2 diabetes. So we know that, and there are many studies showing the same thing. You can use the waist circumference to do the same, make the same graph. We also know that losing weight can prevent the onset of diabetes. So people who are getting diabetes as they gain weight, if they bring their weight down, they will not get it. And this is the diabetes prevention study, again from the United States, but again, there are several studies showing exactly the same thing in other populations. Lose a modest amount of weight, in this case about 7 kilograms, the blue line on the left, and maintain that weight loss quite well, not very well, but quite well for 4 years, so they're still 4 kilograms below baseline. And that is enough to prevent more than half cases of new diabetes, a 58% reduction in new diabetes. Now, that's not a huge weight loss, but it's taking away most of the diabetes. So this is a disease caused by weight gain. and its development can be prevented by weight loss. The big question, of course, was, can we actually turn this around once people have actually got diabetes? And anecdotally, I had seen patients over the years who appeared to have done that, but we didn't have any proper evidence. We did have a famous study from Scotland many years ago. This was published in 1990. And again, it shows years of life lost compared to people who never had diabetes. So these overweight people with type 2 diabetes, if they lost no weight, that's the 0 on the horizontal axis, x-axis, they lost about 7 years of life. That was exactly the same back in 1990 as it is these days, even with all our modern treatments. As they lost more weight, their life expectancy increased, such that by the time that they had lost 14 kilograms, 15 kilograms, their life expectancy was in fact exactly the same as people who never had diabetes. So it appeared that they had not only stopped the progression of their disease, but they'd actually stopped the complications of diabetes. So that figure of 15 kilograms came from that study of ours back in 1990, suggesting that the disease and its complications might be reversible. Surgeons, bariatric surgeons, have been saying for years that type 2 diabetes can be reversed. And this is a collection of studies from bariatrics, different operations in different centres. And the blue column looks at 2-year data. And you can run your eye across this. And with the weight losses that they're achieving, which are shown there as well, they're 25 to 35% weight losses, massive weight losses with bariatric surgery. They're getting a remission rate of between 68 and 85%. So the great majority of their diabetic patients can get rid of their diabetes for at least 2 years. Unfortunately, after bariatric surgery, there is still some weight regain, and later figures in green show that the remission rate is it falls, but it's still there. So a high proportion, over a third and perhaps a half, can remain free from diabetes for 5 years and even 10 years if they lose a substantial amount of weight. But that isn't available to everybody, and it certainly incurs costs and complications. So we proposed a study which would look at this without using surgery. And the reason that we had the sort of courage to do that was that a single small study compared bariatric surgery with continuing in the diabetes clinic to see who had remissions of their diabetes at 2 years. They got a 73% remission rate at 2 years, and this is from a study in Australia. And you can see the individual cases here. The open symbols are people who were free from diabetes, not requiring medication at 2 years. And the more weight loss, the more likely they were to do it. Now, what I did was to put a line at our figure of 15 kilograms. 15% of 15 kilograms is the same thing because they weighed on average 100 kilos. And at that point, 83% of people who lost over 15% or 15 kilos were in remission. And in fact, I could have put that line at 10 kilograms. It's a very small study, and we don't really know what happened between 10 and 15 kilograms. There wasn't enough information. But that does suggest that you don't need to lose 20, 30, 40% of weight or kilograms to get a remission of diabetes. And that should be achievable without surgery, using our slightly more up-to-date methods. So that was the history behind the diabetes remission clinical trial carried out in Scotland and in the northeast of England, where my colleague and friend Roy Taylor had a subset. I'll tell you about them. Everybody in the study, in the control group and in the intervention group, followed our best clinical practice guidelines for treatment using drugs for type 2 diabetes, and that's the NICE guidelines in England and the SIGN guidelines, which are the sort of older ones, and in Scotland. I was going to say better ones, but I mustn't say that. And the intervention group additionally had a weight management program, which we had been developing with research and publications over about 10 years, called Counterweight Plus, and I shall explain that to you as well. We randomized patients by practice. We tried to get patients who were absolutely typical, ordinary people with type 2 diabetes. So these are not special people in any way. Their average age 54. They'd had diabetes for 3 years on average, and we limited our group to those who with diabetes for less than 6 years, because we know that if you've had diabetes longer than 6 years, longer than 10 years, then there's a lower chance of remission. They had an average BMI of 35 and a hemoglobin A1C 59 millimoles per mole, which is about 7.3 And we selected people from the most deprived parts of the community, because that is where most diabetes is found and where it's most difficult to treat the disease. So we really gave ourselves quite a stern test here. And the program that we put them through looked like this. It was delivered entirely in practice, in the villages, in the local surgeries, by a practice nurse after 2 days training, or a dietitian if there was a dietitian available. And in many parts of Scotland, we have dietitians who go into the practices once a week or once a month. And that's what they did. Now, on day one, we asked the patients to stop all their medication, stop their diabetes medication, stop their blood pressure medication, and their diuretics if they had them. And the reason for that was for safety, because we then on day one asked them to go onto total diet replacement with a formula diet. Formula diet providing 850 kilocalories a day. So not technically a very low calorie diet, but certainly low calorie diet. And if people do that on medication, they would risk hypoglycemia and postural hypotension. Blood pressures could fall, and we've had blackouts in people who've done this without stopping their medication. So we told them to stop their medication on day one, go onto this diet program, and stopping the medication was a very big incentive to people who have type 2 diabetes. They don't like taking medication, and the idea they could control this disease completely without medication was very attractive to them. We asked them to follow this program for 12 weeks. Now, some of them had holidays and reasons for not doing it every day, so we allowed them a bit of slippage up to a total of 20 weeks. And then they went on to food reintroduction, which meant bringing back one meal a day from foods. Now, I would say ordinary foods, but these were not the ordinary foods that these people had been eating while they had diabetes. While they were gaining weight, being overweight and having diabetes, they had what they regarded as a normal diet, normal lifestyle, normal diet. Who isn't like that? But we were asking them to make a change towards a diet which would allow them to maintain a substantially lower weight. And that has to be different, completely different from how they lived their lives previously. They found that quite testing. They needed support. And in order to get to that point, we had been putting them through a regular program from day one of this entire intervention, preparing them to go on to long-term weight loss maintenance with the dietitian or the practice nurse and workbooks which we provided for them. They then went into long-term weight loss maintenance, initially for 2 years, but because of the results of this trial, we've continued them for 5 years, and perhaps at the beginning of next year, we will have the results from those 5-year data. The study was designed to get a remission rate of over 20%. We went for 22%. It's the first study ever conducted to try to get remission of diabetes as its primary endpoint. And by remission, we mean no longer diabetic, hemoglobin A1C, which is no longer diabetic according to WHO criterion, that's below 6.5%, and free from all diabetes medication, in this case for 12 months. Now, Dr. Rothberg and her colleagues have from UK and the United States have put together a consensus statement just last month, which confirms that this should be considered the remission of type 2 diabetes. You don't need to wait 12 months before confirming it. 3 months is sufficient. And the reason for that is that it takes about 3 months for hemoglobin A1C to settle after stopping medication and after losing weight. So we aim for 20% or 22% remission rate, and we assume there'll be a control group remission rate of about 5% because people heard about the study, and some of them went off down the road and jolly well lost weight because they thought, well, I'm not going to wait for the results of this trial, I'll lose weight. So some of them actually did that. We were told to get 280 patients to be statistically powerful, and we actually got over 300 and had to stop recruiting because it was a very popular trial. The remission rate that we actually got, and many of you will know this, was almost half, 46%. And that was with an average weight loss of 10 kilograms. So half the patients lost more than 10 kilograms and almost half were free from diabetes at 1 year. Way better than our recommendation. The reason we tried to get 20% remission rate was because our public health doctors said, if we do, we'll have to change our strategy for managing diabetes nationally by the National Health Service. So they've had to do that. Also because we thought we come from Scotland and we can do anything we can do far better than anybody in North America. And of course, the Look Ahead trial did get a remission rate of about 10% with a weight loss of somewhere around 8 kilograms. So, which is not bad, I shouldn't tease them. 2 years, we followed these patients up. The remission rate then was 36%. And you can see the mean weight loss has fallen. And the reason that the remission rate had fallen from 46 to 36% was because 15 individuals regained weight. And that's a tragedy for them. It was disappointing for us. And the ones who relapsed into diabetes, their weights were closer than 10 kilograms to baseline. So it did seem that if they can get the weight off and keep 10 kilograms away from baseline, there's a very high chance of maintaining that remission. And we've looked at this in a bit more detail here in a more recent paper published just last year. And if you look at the right-hand side here, patients who lose 15% of their weight, 15 kilograms, again, they were 100 kilos at baseline, at 1 year, 86% were free from diabetes in remission. At 2 years, 82%. So if the weight loss is maintained, in this case at over 15%, 15 kilograms weight loss, the remissions will be maintained as well. And you can see that that is the case for 10 to 15 kilograms weight loss and even for 5 to 10% weight loss. And of course, these individuals are nearer to 10 than to 5. But if you want a really good chance of a remission of diabetes, and we're looking at over 70% for people who lose and maintain weight loss of over 10 kilograms. So this is very good news for people with diabetes. They really can get a remission, and if they keep the weight loss off, they will maintain that. I mentioned we stopped the medication for blood pressure. A lot of doctors were anxious and some patients were anxious about that. But we assured them that this was going to be safe, and sure enough, it was safe. In the white line here, you can see the blood pressures of people who were not on blood pressure medication. And and this graph shows the period on total diet replacement, the formula diet period. These are the visits, not the weeks. And in that white line, you can see their blood pressures fell very rapidly. And some of this is an average, so half of them were losing more than that, I beg your pardon. And they were approximately 10 millimeters of mercury lower than at baseline. Similarly, the green line shows people who were on one medication for blood pressure, and the yellow for people on 2 medications. They all fell to about the same point. So at the end of the total diet replacement period, with an average weight loss of around 10 kilograms, blood pressures fell by 10 millimeters of mercury. So the message here is that weight loss is a very potent treatment for hypertension. And if you carry on the medication, there's a serious risk of postural hypotension. About 30% of our patients did require to go back onto one medication as their weights leveled off, and I've put that in the box here as well. So this is a safe protocol, and it allows people many people to get off treatment for blood pressure as well as treatment for diabetes. At the same time, their fatty liver disease also improved, liver function test improved, and their lipids improved. We looked at serious adverse events, as one should in any clinical trial. Now, in most clinical trials, the worry is serious adverse events in the intervention group. In this case, the serious intervention group, serious adverse events were more common in the control group. So our intervention group in the red had fewer serious adverse events and significantly fewer in the second year after we started the program. And those events were, I've shown them here, they were very small numbers. But they are mainly diabetes-related cardiovascular and cancer events. And I think it is important to recognise that diabetes and overweight promotes several different types of cancers, which feature here. And they are seen not exclusively, but mainly in the control group. So the weight loss seems to have at least suppressed these or delayed adverse events. And we'll see in the 5-year data what they look like. The sort of bottom line in this study is that at the end of 2 years, there were fewer patients requiring medication for diabetes and on average a lower hemoglobin A1C. The blood pressures likewise were lower with fewer on medications. Cardiovascular risks were reduced. And the upshot of this is that the medical care costs were substantially reduced. And we've done detailed analyses of the health economics of this intervention. They required fewer drugs, which are expensive drugs for diabetes and blood pressure. There were fewer serious adverse events. There were fewer referrals to hospital and consultations, both to doctors and to physiotherapists and to dietitians and other healthcare workers. And as Amy Rothberg mentioned, with this degree of weight loss, there is a substantial improvement in quality of life. People who lose 5 kilograms in weight, it's hard work. They don't have much to show for it. There is a significant improvement, yes, statistically, but they don't feel any different. Lose 10 or 15 kilograms and life changes. and people feel a lot better. So it's kind of win-win-win. And I'm not going to try and talk you through this very detailed economic analysis, but the bottom lines here are that our patients were set to live longer, to feel better, and cost less to themselves and cost less to our healthcare service. So it's a kind of win-win-win intervention. The same intervention, this was delivered, as I mentioned, in primary care by a nurse or a dietitian. The same intervention is now being delivered entirely remotely, so that the formula diet is provided to people in their homes, and that is being done by, I think, most of the companies who provide formula diets for weight loss. The program for support, which was in our case was tailored very specifically for remission of diabetes to maintain that weight loss in the long term, is also being delivered remotely, using all the clever means that we have with Zooms and WhatsApps and telephone. I should mention that the telephone was invented by a man called Bell, who was Scottish, and I'd like to flare our flag for that. The telephone, we've only just learnt how to use the telephone in medicine, and patients love it. They appreciate being phoned up or called by Zoom or WhatsApp, and not required to go and drive to a surgery, sit in a waiting room, perhaps be delayed for some other reason. They can do it all from home. And the weight losses we're getting, 15 kilograms on average at 12 months, are actually better than we had with face-to-face. So that's good news. My colleague Roy Taylor in Newcastle, at the same time, took a subset of our patients in the direct trial, and he put them through these detailed investigations. And I shan't go into this in too much detail, but the blue columns here show what happened in MRI scanning in the liver fat, which was high at baseline, and it fell in those in remission of diabetes. With the liver fat falling with weight loss, there was a reduction in VLDL. That's the fat, the lipids which come out of the liver and are then transported around the body, and that fell also. And with that, the fat in the pancreas fell. I'll show that in more detail. So all these moves removed what is known as ectopic fat, the fat which has accumulated in all the wrong places in the vital organs. And in these people with type 2 diabetes, metabolic syndrome, that ectopic fat was removed. In the greenish column and the orange column here are individuals who did not get remission and who relapsed, and you can see that they did not see the same improvements in liver fat, VLDL, or in the pancreatic fat. And in fact, the VLDL actually rose in the people who gained weight and went back into diabetes. So it does appear very clearly now that type 2 diabetes is being driven, and perhaps the whole sort of insulin resistance story is being driven by an excess of fat, which is accumulating ectopic fat in the wrong place in vital organs around the body. If you can get rid of that fat, the organs seem to function again. And that's shown so vividly by the pancreas. This, at the top of the slide, shows scans of a pancreas. Now, the one on the right is a perfectly normal pancreas. I'll see if I can point to it without moving on. That one is a perfectly normal pancreas. And at 2 years after remission of diabetes, here's a patient whose pancreas is again normal. Compared with how it was at baseline, a ragged, miserable-looking, sick pancreas. And we put measures on this. The volume of the pancreas with diabetes is half normal. This raggedness is doubled. And at the bottom, patient with type 2 diabetes, as we described right at the beginning, they can only make half the normal amount of insulin. That returned over 2 years to normal. So the pancreas beta cells gradually recover if there is sufficient weight loss. And the pancreas can then produce the normal amount of insulin again. And that's telling us then really what's happening across populations. So in any population, and these figures come from North American data, about 60% of people do not have the genes for metabolic syndrome or epigenes. And if they gain weight, they remain mostly fairly happy, but they do have a small increase in heart disease. And it is quite a small increase in heart disease. It is very real, it matters to those affected, but it's relatively small. However, 40% of all people in North America, and it's more in the Middle East and in Asian countries, but 40% in North America, if they gain weight, they will put fat into vital organs, ectopic fat in the pancreas, in the liver, and in the heart. And they will develop type 2 diabetes, fatty liver disease, hypertension, and they will get a very high rate of early heart disease, strokes, and microvascular disease with complications of diabetes if they have it. Now, what we've shown in the direct trial is we can reverse that process, and that's hugely important for those individuals. What we don't have is a smart way of identifying people at risk at a very early stage. Although we do know that if you're a family with type 2 diabetes, you're unfortunately very likely to have those genetic predispositions and should avoid weight gain. We can't easily measure the fat in the liver without an MRI scan, not reliably. But the minute somebody shows themselves as having pre-diabetes or diabetes, we know for sure that they're heading for trouble, and they should be advised to take a program such as the one we have used in the direct trial. I promised to Andrea that I would mention waist circumference. I've already mentioned it once. The waist circumference is a very useful, simple guide to general population, people as health promotion, to let people know who is at risk. And that applies particularly to people who are not yet very heavy, because some people who have this metabolic syndrome predisposition start to put fat into the vital organs even before they are technically overweight, before their body mass index reaches 25, at a level which many people would think was quite thin. If they are, then their waist will tend to be a little higher than normal, because with thin people, and when there's not a big range of body mass index, the waist does reflect fat, intra-abdominal fat in vital organs, apple-shaped fatness, if you like. However, if you then look at the waist circumference in populations where you've become very overweight, when the body mass index is above 30, above 35 certainly, then the waist circumference really doesn't tell you any more than the fact that these people are fat. You have too much body fat, and it's similar to the body mass index in that regard. It's actually slightly better as a predictor of total body fat. So that's the story on the waist circumference. It's useful for health promotion to identify people at risk when they're younger and before they become seriously overweight. And I should mention, I think I have, that there are big racial differences. So Asian people here, this is Professor Ranjan Yajnik from India, and John Yudkin, who's not Asian, have the same body mass index, but completely different waist circumference and intra-abdominal fat distributions. The principles that we used in the direct trial have now been codified and published as what we call the direct principles. They were published by Diabetes UK to make it clear that this is a generic, we believe this to be a completely generic phenomenon. In other words, if you have a program which will produce a weight loss greater than 10 or 15 kilograms ideally, and maintain that weight loss, then you will get a remission of diabetes. And that has been published in diabetic medicine. There's nothing special about the program that we use, the Counterweight Plus program. It was a good one, but we did develop a very good program for personal support, which has been now codified, and that is the important part about maintaining the weight loss long term. There have now been 2 clinical trials looking for remission of diabetes, ours in Scotland, and then a second trial called Diadem-1, which was conducted in Qatar, in the mainly North African population, the Arab population. They both got very good weight losses, 10 and 12 kilograms in Qatar. The remission rate was even better in the Diadem-1 trial. It's 61% at 1 year compared to 46% in direct. But you'll see also that the usual care did produce a remission rate of about 12% here without that degree of weight loss. And the reason for that is that they had patients who were much younger and had much more recent onset of diabetes, so it's closer to diagnosis. And the message here is treat this disease much more seriously and much earlier with sufficient weight loss to get rid of it. There have been several studies which have attempted to look retrospectively, not aimed at getting remissions of diabetes, but since our publication, a lot of people have then looked to say, oh, maybe our trial, perhaps we could claim that our intervention produces remissions of diabetes. Some of them are better than others, and most of them have looked at low-carb diets, because that seems to be a very sort of trendy thing, especially in North America. There's a company called Virta Health, which published a study with very good weight loss, marvelous weight loss of 13.8%, but the remission rate of diabetes was only 19%. Now, part of that may have been a sort of slightly artificially low figure because they didn't actually stop the medications in all their patients, so we can't really say whether they a few more who had remissions. But at the moment, the evidence does not support a low-carb diet or ketogenic diet. That was a ketogenic diet for trying to get remissions of diabetes. A GP in England called Unwin used the same diet, a ketogenic diet, for all his patients, and he got a 12.5% remission rate across his entire practice. That's actually very good at 2 years. And the people who really stuck to their diet relatively small numbers, about a quarter of them, they did have a remission rate of about 46%. So if you can, he did not measure the weight losses, but from anecdotally, there were a lot of good weight losses there. A couple of other studies have looked at remissions retrospectively without terribly impressive results, again with low carb diets and with the LCDs. Gathered up by Goldenberg. And then I mentioned earlier the Look Ahead trial, the biggest ever trial conducted in type 2 diabetes, got a weight loss of about 8.6%, which is quite impressive, and then a remission rate of 11%. So 11%, we should respect that, because it wasn't actually targeted at getting remissions, and a lot of their patients had diabetes much longer than 6 or even 10 years. So it wasn't designed to get remissions, but they were there. I throw this slide out if we may want to discuss it. It's a big meta-analysis of low-carb diets against other diets, which found no benefit for hemoglobin A1C, for weight, for lipids, for blood pressure, or anything. They're equally good or equally bad for the patient, but there was nothing to choose between high or low carbohydrate diets from that point of view. We've also conducted another meta-analysis which has looked at different diet patterns to try to get weight loss specifically in people with diabetes, and found pretty much the same thing. So I'll skip over that slide. In my summary, I would say that things that I'd like people to remember are that type 2 diabetes is a much more serious disease than perhaps we previously had understood. We should treat it much more seriously and take its management much more seriously, guiding people, supporting people as early as possible after the diagnosis. We do now have evidence from what is currently an optimal diet program. We should aim to use it from diagnosis as soon as possible and aim for remission. And I would say for Europeans, we definitely aim for 15 kilograms or 15% weight loss. We may get away with less in Asians, and I'm just reading between the lines here. We don't have evidence for that, but remission may be possible with less weight loss in Asians. And the best evidence that we have at the moment from 2 very convincing trials is using a low-calorie formula diet as total diet replacement for a period of time, approximately 12 weeks, but with a big focus on maintaining the weight long term. And that, just a reminder at the end, not everybody requires a formula diet, and I think it's important to say that, although that is where the best evidence is. There are individuals who don't like the idea, and they're a minority, but we found that they can respond to diets based on traditional foods. In Scotland, we have the No Doubts diet, which you can Google up if you're interested. It basically has porridge in the morning, lentil soup at lunchtime, and another different lentil soup at tea time. And you do that for your 12 weeks, 850 calories a day. And for some people, that works. In Nepal, we've used a similar traditional diet again, but this is quite different. It's a milk-based breakfast, and then dal bhat, very traditional food in small helpings, to provide 850 calories a day with vegetables. These are nutritionally balanced approaches which can get the same end. Oops. And on that happy note, I would like to thank you for listening, if you have. And also my big thanks to Diabetes UK, which is a charity. It's not quite the same as ADA in America. It's totally a charity run by and for patients with input from professionals. And it's kept afloat by donations from people who have diabetes in the family and such like. So it's no government funding and it's not commercial funding. Thank you very much indeed.
Thank you, Professor Lean. That was really excellent. Sorry, everybody, that we've run over, but we do have if you're able to stay, we'll try to answer just a couple of questions. But I'm really looking forward to hopefully seeing that 5-year data, Professor Lean. So the way that it will work is, again, type in your question in the chat box, and we will go ahead and answer them. So there's a couple that have come through. So the first one is, what kind of pain were you referring to, Dr. Rothberg, in the obese females? So is that generalized pain, pain during labor, or joint pain?
Thank you for the question. It's actually diffuse generalized pain, as we see in fibromyalgia, so not exclusive to weight-bearing joints, and not during pregnancy or postpartum.
Okay. And then I think the next one here is for you, Professor Lean. So it's really kind of more of a comment, but my experience is that measurement of waist circumference is a good indicator to start off with. but following up with waist circumference is quite frustrating, and it is hardly the outcome change with diet alone. Can you comment on this?
Well, waist circumference is something which ordinary people can measure themselves, and they don't make a big mistake. If you can use the size of your trousers, and we published a paper, if you wear trousers, which does the same thing. It's a useful guide if it's done properly by a professional who's using the correct technique. Then the waist circumference does give a better indication of total body fat, and it can be used to follow weight loss in kind of clinical trials. However, if you've established that somebody is going to go into a trial or is going to take on a treatment for weight loss, the best measure is the weight, and I only use the weight to look at the success and to show whether patients are actually following the program. If the weight goes down, they're following the program. If it doesn't go down, then they're doing something else. Patients themselves actually quite like monitoring their waist, and they come along with their belts, and they're proud of the fact that their waist has gone down. They look better as well.
Makes sense. Thank you. So the next one is, in people of greater than 150 kilograms, would you ever do higher calorie restrictions?
Thank you. That's a
so
really
actually for both of you, probably, yeah.
That's a really important question, and I should have mentioned that. So if people are very heavy, and I wouldn't wait until they're 150 kilograms, that's enormous. But people who are over about 110 or roughly 110, 120, we would generally start with 1,000 calories, and in some cases we got 1,200 calories to start the process. The reason for that is it doesn't really make any big difference because the restriction is still enormous. But in terms of tolerability, we find that patients who are very overweight, above about 110 or 112, 120 kilos, do find it a little bit easier if you can start them off with roughly 1,200 or 1,000 calories first. And it's probably also worth mentioning that when people take on this program, we're going to ask them to do this, whatever this is, for 12 weeks, which is quite a long time. We often give them a weekend first and say, look, would you go and try this for a weekend and see whether you think you're going to be able to do it? Because it's better to know at the very beginning whether they're ready and able and willing to do this. And they find it quite a useful way of biting the bullet, if you like, and saying, OK, I've done it for 2 days, I'm going to give this a go.
You're muted.
No.
I was going to say, Dr. Rothberg, I was going to say, I know you've done a lot of work with severe obesity. What's kind of your thoughts on this, and do you guys do a similar type of kind of protocol?
So I will echo what Dr. Lean said about increasing the number of calories for those people who are heavier. We don't really do a test case. Maybe we should, but most of the people whom we see have already had more than 8 attempts at weight loss. They're just ready, and they're actually feel like if we can unload them of any decision making, they're ready to bite the bullet and do the 12 weeks. It's actually a relief for them.
Yeah, I can imagine. The next question here is, do VLCDs work for newly onset type 2 diabetes in relatively normal weight individuals? So those with a BMI of 25 or less?
Yes, of course it does. Anybody who follows, any human being who follows 850 calories a day will lose a lot of weight. However, for people who've got their diabetes with a body mass index of 25 or 24 or 23, and they need probably to lose less weight to get clear of it, and that's sort of common sense, and that applies to the Asians, which is why I mentioned this in my talk. So a lot of our Asian patients have a body mass index of 23, 24, 25, and for them it looks like 10 kilograms weight loss may be sufficient to clear the ectopic fat and get clear of the diabetes.
I don't know. If Dr. Rothberg, you have kind of any comments on this with respect to newly onset?
No, I identify entirely with that. I mean, it's better to get people who are new onset. They have a better chance of remission.
Let's see here. Another question focused on 10 to 15 kilogram weight loss versus overall percent weight loss. So which do you tend to try to track, or both?
Well, I can sort of give you an answer on this. In most clinical trials, the average weight is about 100 kilos. And I mean, extraordinary how many of them are very, very close to 100. So it doesn't actually make any difference whether you talk about percent or about kilos. It does make a difference when you then talk about individuals who are not in clinical trials who might be 150 or even 200 kilos. And at that point, if you are asking people to lose 10% or 15%, if you're 200 kilos, then you're asking to lose 30 kilos, which is, you know, a lot. In the direct trial, we analysed this very, very carefully. We did have individuals going up to about 160 kilos, which is about as high as, you know, we find people usually in the UK. And it was still a roughly 15 kilogram weight loss was still effective in people who were very, very much more overweight. So what it looks like is that when you get your diabetes, the last 15 kilograms you put on was the 15 kilograms that's now gone into ectopic fat, into the liver, into the heart, into the pancreas. So it's the last 15 kilograms you put on, you've got to get rid of it. And some people will get their diabetes at a weight of 75 kilos. They've got to lose 15, or perhaps there's only 10 at that point. Similarly, people who are 150 kilos still only have to lose 15 kilograms to get rid of their diabetes. So it doesn't make a big difference. We've analysed this to death. It doesn't make a big difference, but it seems like the last 15 kilograms that people have put on is what has done the damage.
Makes sense. So in the interest of time, I'm going to have Dr. Rothberg answer one more question, but I did want to make everybody aware that we are recording the presentation, and also we will make the slides available. So we are capturing the emails. So if you would like a copy, you can go ahead and put that into the chat box, please. So the last question here, actually, I think Dr. Rothberg here would be, can you please share your experience with using meal replacement liquid drinks in bariatric surgery? I know you've done quite a bit of work with that.
So it is a very useful approach, specifically to reduce or to control glycemia prior to pregnancy and to reduce liver fat. And so I think it's very varied across centers across at least the United States. I'm not sure across the UK and Scotland, but in general, they do at least 2 weeks. It's a much greater calorie restriction to the tune of 500 kilocalories per day in the form of liquid meal replacement. And let's be clear, for that, and maybe Professor Lean will disagree with me, but it is in order to be nutritionally replete, we have to do it by meal replacement. It is very difficult to get to that degree of calorie restriction by food-based diets.
Yeah, I agree with you.
Yep, that makes sense. Absolutely.
Some individuals can, but not many.
I think just the last one here, when you say VLCD meal replacement in the study, can you provide more details about the macro percents used?
No, you're talking of the direct trial there. I should have mentioned this. The macronutrients in a diet of only 850 calories don't matter a bit. In point of fact, all formula diets, or virtually all formula diets, are relatively high in carbohydrates, and it's important to include some fat in order to protect the gallbladder, because gallstones can easily form if you don't include some fat in the diet. For the long-term maintenance, we used a diet which was not high, not low in carbohydrates. It was approximately, we based it around 50% carbohydrates, which is relatively high, but we allowed flexibility. So if some individuals wanted to reduce carbohydrate a bit, they did. Nobody wanted to go onto any kind of ketogenic diet out of our 150 patients in this trial, and in fact, nobody I've met subsequently has wanted to do that. But there are some who want to vary that, and we allowed flexibility. And I think one of the important things we learned here is that if we want to help the maximum number of people, we have to be able to be flexible and to bring them in slightly different ways. However they do it, losing the weight will get shot of their diabetes in most cases.
All right, well, thank you for that. We have run over significantly, so thank you for all of those who stayed. So on behalf of Nestle Nutrition Institute, as well as Nestle Health Sciences, I'd really like to thank everyone for attending. Hope you enjoyed the webinar. There will be a follow-up post-evaluation survey coming, so we really would appreciate it if you take the time to answer that. And we hope to see you at another program. So thank you again, and goodbye.
Cheerio, and thank you.
Thank you.
Yeah, bye.